So today's video is about vestibular rehab. If you have been referred to vestibular rehab or diagnosed with some condition for an inner ear or brain disorder that causes dizziness and in need of VRT or vestibular therapy exercises, you might want to know, are they effective and what's the research behind it? I recently got a question from our community here at Treat Dizziness at Home that says, hey, can you please share some evidence behind your gaze stability exercises? So I think that's a great idea. I've wanted to do a video about the evidence, review the literature with you, and just let you know that there truly is research behind what we are doing and that it is effective. Now, in many of my videos, I do link evidence of a research article or something like that, just supporting where I got the information, but maybe it's not in all videos. So I think it's a great time to review and rediscover the evidence behind vestibular therapy exercises. Let's share the screen and go over what is currently in the evidence. So we are going to start here with one article. It is a revision of an article in 2016, so an updated review of all the literature. So what they're doing is taking a look at each research article that is out and identifying its strength of its evidence, its methods, its subjects that it did study, and it's coming up with our best clinical guidance for vestibular therapy professionals when treating patients suffering from dizziness. So this is from the APTA, American Physical Therapy Association. The authors are Courtney Hall, Susan Herdman, Susan Whitney, and more. And those are some very big names in research in vestibular therapy. So if we go back here to the title, and this is pretty important, we are discussing in this evidence an update for clinical practice for vestibular hypofunction. So let's go through what a hypofunction is. Vestibular, we have two on each side, which is an apparatus outside of the brain that has a nerve that goes to the brainstem, tells the eyes and body what to do. So our vision remains stable, our balance remains stable, we don't have dizziness or veering when we walk, nausea, and any kind of bouncy vision or just feeling unsteady or kind of wonky in the head. Those are some symptoms that you might feel with hypofunction. So when one of those apparatus, the vestibular system, has been dysfunctional, has been diseased, that could be from a neuronitis or a viral attack. It could be from a concussion to one side. It could be from an acoustic neuroma or a tumor on the 8th cranial nerve. So any disease process that impairs the nerve is a hypofunction. Now, that could be one-sided or both-sided, so unilateral or bilateral. And the research does discuss recommendations for both. So if you have any questions about what is a hypofunction, you should discuss that with your doctor, your vestibular provider. You would probably be diagnosed with a hypofunction from your medical provider or through a VNG, a video nystagmography. And that specifically looks at the strength of your vestibular nerves. So if you've had that test or you talk to those providers and you've been diagnosed with a vestibular hypofunction, this video is what we're talking about. Gaze stability exercises, vestibular adaptation. So trying to make sure that the brain can accommodate for losing the vestibular nerve weakness in one or both ears. All right, so let's go through here. This is kind of the abstract and methods. So I think that might be important just to discuss here. As I mentioned earlier, an uncompensated vestibular hypofunction. That means that the brain hasn't adjusted for the weakness in your lack of a function for the vestibular nerves. To compensate, we do gaze stability exercises traditionally. And that's what this video is all about. Is this effective? Is this an effective treatment strategy, or do we do nothing and just let it go? So as we mentioned earlier, symptoms of dizziness, imbalance, oscillopsia, which is that bouncy vision I referred to, gaze and gait instability. So the eyes might feel like they bounce a little bit when you walk, or unsteady or blurred, and veering with walking. So of course, as you know, this impacts people's lives, their ability to drive, work, take care of their kids, participate in family outings. And just background here, strong evidence of supporting vestibular physical therapy for reducing all of those symptoms. So what did they do with these research articles? They did look at different articles looking at the acute, meaning that first 7 to 10 days, or even earlier, subacute, which is more in the neighborhood of the 2 weeks, versus chronic, anything past 3 weeks. For one side and both sides. A revision of 2016 articles. So these articles that we're discussing today were taken from 2015 to 2020. Let's go through the series of action statements. Now, what those are, they just kind of condensed the findings for us, so it's easily digestible, easy to understand, and we will go through each of those action points now. So statement number 1, looking at the effectiveness of vestibular rehab with early, that first 2 weeks of unilateral hypofunction. Clinicians should be offering vestibular therapy to patients in that new stage of vestibular hypofunction. So what does that mean? The earlier the better, basically, with vestibular therapy is good. So if you have suffered vestibular neuritis or labyrinthitis, something that insults or gives you a dysfunction of that one nerve, you should be starting therapy as early as possible, is what this is suggesting in the evidence. We shouldn't be waiting 20, 30 days or months longer and saying, with rest, your dizziness will get better. The evidence does not suggest that at all. For someone who has lost function of that inner ear, we should be modifying our exercises so they're tolerable and not making people sick, but you should be starting early. So action statement number 2. Effectiveness with vestibular therapy with chronic, so longer than 3 weeks. We should be offering vestibular therapy to those clients as well. So what the evidence did suggest, though, is that if we get to you earlier, you might have a quicker recovery plan. In the more chronic stages, you're still going to have that benefit, but why be in misery? Why be suffering for that 3 weeks leading up to it? Rest is not best. Get into vestibular therapy. Action 3, effectiveness of vestibular rehab in adults with bilateral hypofunction. So the evidence is there for one or both vestibular dysfunctions. I think that's important to know, because a lot of providers, especially I would say when I was working even 5-6 years ago, a lot of people would just say, this is how it is, just use a walker, use a rollator, and do what you can, but they really wouldn't refer to vestibular therapy. And that was not too long ago. So action statement number 4. This is an important one that we need to discuss. Effectiveness or saccadic or smooth pursuit exercises for people with one or both sides of vestibular hypofunction. There is strong evidence that it is more harmful than beneficial for therapists to give their patients just eye movement exercises in isolation. So that's looking like this. So if I have my targets and I'm just looking left, right, left, right, left, right, not moving the head, that is not a vestibular gaze stability exercise. Smooth pursuit would just be eye tracking back and forth, up and down. That should not be prescribed for vestibular hypofunction, strengthening that inner ear again. Now, disclaimer, you will see some of my videos doing those same exact exercises, but it is not for a hypofunction. There is no claim that I ever make that eye tracking is strengthening the inner ear. Now, if somebody has visual vertigo, migraines, 3PD, where they're getting dizziness with this, we will habituate to those eye movements until we feel safe in our body again and until there's no dizziness. But those do not strengthen the inner ear. Those should not be gaze stability exercises that are prescribed for a weakness of one or both ears. So they do have value, but not for a hypofunction, and they are not qualified as gaze stability exercises. The gaze stability has to involve head motion. So all your VOR, VOR near, VOR far. VOR just means shake your head. So it is abbreviated for vestibular ocular reflex. When I move my head to the left, my eyes should go right. That is your VOR. That is what the vestibular system does. And that is how you actually do gaze stability exercises. So if you're not familiar, I will pin my latest video on beginner vestibular rehab in the comments below. So go ahead and check that out, because that is what you need to be doing for hypofunction. So moving on, I think I stressed that enough that you should not be doing eye movements in isolation for vestibular rehab. So anything that moves the head with the eyes or opposite of the eyes, that can be a vestibular exercise for a hypofunction. Okay, moving on. Action statement number 5. Comparative effectiveness of different vestibular rehab in individuals with hypofunction. We may provide targeted exercises with specific goals. Okay, that is fancy for habituation, and that program should be individualized to your needs. So we have our vestibular therapy where it's the back fourth, our gaze stability. Then there is a whole targeted vestibular program for habituation. So let's say, for example, I get dizzy, or I have a client that gets dizzy when they put the dishes away in the dishwasher. So we will work on slowly balancing and moving our head down and up, putting dishes away like we're simulating a dishwasher, and just trying to do it in a slow, controlled fashion until we let the brain feel that over and over and over again until it desensitizes, meaning not causing symptoms anymore. So there is strong evidence that habituation exercises do work in addition for treating hypofunction. All right, let's move on to balance dosage. Okay, I think this is super important. So here we're actually looking at the evidence on how long should we be prescribing exercises, and this is very important. So static and dynamic balance exercises for a minimum of 20 minutes a day for 4 to 6 weeks for one-sided loss. Remember, static would be our balance exercises that might be standing on one leg, standing heel to toe, just anything balancing where we are in place. Dynamic is going to be when we start adding head motions to those balance exercises, or walking heel to toe, or walking marches, or walking with head turns. Anything that's on the move or involves arm movement, body movement, instead of just standing in place. But for 20 minutes a day for 4 to 6 weeks for unilateral, one-sided hypofunction. And then for bilateral, it actually recommends 6 to 9 weeks for bilateral hypofunction. So not surprising that if you have both inner ears dysfunctional, that you're going to need some more time to get that max rehab potential in your balance exercises. All right, let's move on to, which is, again, super important, dosaging our gaze stability exercises, one-sided and both. Okay, so gaze stability at a minimum 3 times a day for a total of 12 minutes a day for that brand new stage. So what I like to tell my patients is I really don't mind if you chop it up through the day, whether that's once or 3 times or 5 times, as long as you're getting a minimum of 12 minutes a day. That's the important piece there. Now, the second part to that is as it moves into the chronic stage, more past 3 weeks, we are expected through the evidence to increase up to 20 minutes a day total for 4 to 6 weeks with that one-sided hypofunction. So as you progress a little bit in your recovery, we're going to ask that you do your gaze stability exercises longer, because you should be able to tolerate those exercises more so as the symptoms subside. And then for bilateral, no surprise, it's going to be a total of 20 to 40 minutes for approximately 5 to 7 weeks. So longer duration as far as daily dosage of exercise and the time frame. Now, looking at the time frame here, 3 to 5 times a day, so 20 to 40 minutes for 5 to 7 weeks, that actually was kind of surprising to me. When I started as a vestibular therapist, initially the time frame was much, much longer. And I think the most important thing to note is that, again, everybody's journey is different. So now, granted, these studies were for a particular time frame. It's okay if it takes you longer. And I will say I did not see anything in this research about how long do we have to do these exercises. Is it just that 5 to 7 weeks? Is it through duration of symptoms? Is it lifelong? I can just tell you anecdotally what I tell my patients is, after we are in the thick of the rehab, so after, maybe that 8 weeks of rehab and you feel like you're at a plateau, we can scale down if you feel like you are where you need to be functionally. If you need to do longer, go ahead and do longer. Some people need more time to progress, and that's completely okay. And personally, I tell my patients that this is probably going to be a lifelong type exercise program, where I want you to at least maintain these exercises 2 times a week, as long as you can remember them and it doesn't bother you, your neck or something as you age. The reason being, analogy-wise, if you had a torn ACL and the doctor repairs it and you go through rehab and it's super strong, and then you stop doing your rehab and you stop walking on it and it's decreasing in strength, do you think your knee pain is going to come back? Yep, it sure is. So I actually have a lot of patients that stop doing their vestibular therapy, they do well, and then after years, maybe they get a little less active, other injuries happen, maybe other illnesses happen, and they go, I'm starting to get dizzy and off balance again. I go, yes, you should probably be doing these exercises lifelong, because if you have an ACL injury, you're always going to do some kind of rehab. If you have an ear injury, same thing. You always should be doing some kind of rehab to keep that vestibular system active. That's my opinion. It is not quite in this action statement, but I did want to throw that in there. Okay, action statement number 7, effectiveness of supervised vestibular therapy. Clinicians should offer supervised therapy to individuals. Okay, what this means, they're finding that there is more evidence to support a trained, qualified professional will give you better results if you have an individualized program that's kind of catered to you. It'll help with increased compliance. It will be a targeted approach, and it will make more sense for your functional impairments. And the exercises should make more sense. Of course, there's caveats to that. Not all vestibular therapists are created equal. Not all have the same background. Not all may be following this advice. So generally, overall, if you do have a really great therapist, you're hoping that the tips and tricks and stuff that we can offer along the way will make your program more efficient, more tolerable, and more effective. And the evidence does prove that. Action statement number 8, when do we stop vestibular therapy? Basically, when you have achieved your goals, whether that is a functional goal of doing X, Y, or Z, or your symptoms have stopped. You're not a fall risk. So we can continue vestibular therapy until your balance is normal, your vestibular function is normal, so you're not having bouncy vision or blurred vision, you know your home program, and you're safe. Okay, now this one, factors that change your rehab outcomes. So what they found was that gender and age did not affect outcome, but what did affect outcome is having a history of vestibular migraine, binocular dysfunction. So if you have something wrong with your eyes initially, maybe with a concussion, or they're finding that concurrently. So if you've been or haven't been to the eye doctor and you notice a lot of vision changes, binocular dysfunction may actually impair your vestibular rehab. A history of anxiety, depression may affect how well you have an outcome. Peripheral neuropathy. So if you cannot, peripheral neuropathy is the lack of sensation in your feet, whether that is from diabetes or chemo-induced neuropathy. So lack of sensation in the feet would also impair your outcomes. And then lastly, being on medication. So vestibular suppressants long-term affects your outcome as well. So if you've been prescribed meclizine for weeks, months, and then start your vestibular therapy, you're probably going to have a slower outcome. Other vestibular suppressants could be benzodiazepines like Klonopin, Valium, Xanax. Anything that is a vestibular suppressant will decrease the likelihood of a quick vestibular rehab outcome. And the last action statement here is the harm-benefit ratio for vestibular therapy. So there is strong evidence that supports that vestibular therapy is substantially beneficial to patients with vestibular hypofunction. And that for a majority of people, if controlled and progressed in an appropriate manner for your comfort level, there should not be any more harm than doing vestibular therapy for treatment of hypofunction. And I think that I really want to drive home that all diseases and dysfunctions are not the same. This article was specifically meant for a weakness of the nerve. So if you have any other forms of dizziness that's causing your symptoms, meaning of the brain or cervicogenic of the neck, then this exercise plan might not be appropriate for you. So if you're finding that you're much worse with vestibular therapy exercises, again, the first thing you should do is be going to a provider that can kind of talk you through how to do the exercises appropriately and make sure they are good fit for you. But this article is pertaining to a hypofunction of the nerve. So just make sure you have a proper diagnosis before going to these exercises and saying, this didn't work for me, and now I don't know what to do. It might not be the right plan for you if you don't have a hypofunction. So I just want to drive that point home that it's a specific diagnosis that these are beneficial for. Okay, I wanted to switch quickly to this little PDF here, which I think is great. It is a synopsis of all those action statements that we just discussed in kind of an easy to read format and drive our points home here. Now, remember, this information is pertaining to how to treat a hypofunction, whether that's one or both nerves. This is not pertaining to any dizziness that is from the brain. So MS, stroke, brain tumor in the cerebellum, Parkinson's, vestibular migraine, that's a brain disorder. So this is not evidence that can be directly to treat those conditions. So I just want to drive that home. This is for the nerves. So what we found earlier intervention improves outcomes. So if you suffer a neuronitis, acoustic neuroma resection, gamma knife radiation, concussion, Ramsay-Hunt syndrome, anything that affects that vestibular nerve, earlier intervention is better. The timed protocol in those first few days to couple weeks, 12 minutes a day. Chronic one-sided loss, 20 minutes a day for 4 to 6 weeks. And bilateral loss is 20 to 40 minutes, 5 to 7 weeks minimum. We also have balance, which is static and dynamic, still and moving. For chronic is 20 minutes for 4 to 6 weeks. For bilateral is up to 6 to 9 weeks. We know here that our outcomes are affected by anxiety and depression, binocular vision dysfunction, migraine, peripheral neuropathy, or long-term use of vestibular suppressants. It is not affected by age or gender. Strong evidence that vestibular therapy works in the research, and that customized exercises are perfect for those with hypofunction. So if you have something that makes you dizzy, you do it until it doesn't make you dizzy, which is the whole point of habituation. For supervised vestibular therapy, they're recommending 2 to 3 weeks in those first initial stages, and then 4 to 6 weeks for chronic if you get started after, and then 5 to 7 weeks for bilateral, at least one time a week, so we can kind of fine-tune programs and make sure that you're on the right path. And then lastly, I want to drive this home because I do see a lot of people saying that gaze stability exercises are eye movements, back and forth, up and down, back, forth, back, forth. Remember, the vestibular system does not work if you do not move your head. So eye motions without head motions are not vestibular strengtheners. So they should not be offered for treating a hypofunction. They do have value for other diseases and dysfunctions, but not for hypofunction for the purpose of strengthening the inner ear. So hopefully you found this video helpful about why we use gaze stability exercises for vestibular hypofunction. Remember to grab your free copy of my gaze stability program, also in the comments and the description of this video. It's a free download. If you have any questions or comments, also leave them in the comments below. I'll be happy to answer them. And make sure to check out my video on beginner vestibular hypofunction exercises that I will link right up here in the corner. Until I see you next week, stay healthy, stay steady, and stay strong.